Thank you, Ahmed, and it's an honor to be here. It's already been such a stimulating morning. My research over the last 12 years have been focused on the intersection of social media and health communication, particularly for cancer control and prevention. So it's evolved quite a bit, and I just want to sort of start by giving you kind of a higher level orientation of why we care about social media and health. And I think these are the four main areas of research. And I should say, besides doing my own research, my day job is really hosting a large portfolio of NIH-funded research in this area. So we write funding opportunities, we talk to investigators, thinking about ideas of doing some cool research in the area. So the first is really this excitement that we can maybe overcome some of the traditional health disparities and the digital divide, because people are on social media and it's information can efficiently, effectively, in some ways, not always the case, be disseminated. So there's a lot of interest in using social media to do health communication that may level the playing field, if you will. And the second type is really using social media as a data source. Where are people talking about different topics? What do they think? Attitudes, perceptions, and behaviors. And the third is mounting health promotion or patient education campaigns or interventions using social media as a platform. And the last one, it's really been a focus of our team the last 2-3 years, is looking at how do we understand the risk and mitigate the risk of misinformation on social media, especially related to health and cancer-related topics. For this, we need both observational and interventional studies. As we began to do this work, I think it was 2007, 2008, and then learning more about Cambridge Analytica scandal and a lot of related issues, we thought we needed to not just think about the traditional public health ways of dealing with, that's not credible information, we need to go after that, or to really come up with a more multidisciplinary research agenda. So we held a working group on this topic. We brought people from journalism, computer science, and health communication together. And following that really engaging discussion for 2 days, we published a couple of thought papers, one in JAMA addressing health-related misinformation, and another in American Journal of Preventive Medicine that's looking at sort of the science of misinformation. And right now we're in the process of putting together a special issue in collaboration with American Journal of Public Health that's all looking at social media, health misinformation on social media. The four main areas of content are surveillance, understanding the context, evaluating the impact, and what kind of responses and interventions are appropriate and effective. So I'm highlighting the context because that's what I'm going to share with you, a little tour of a small study that we put together. And I really like Adam, or I think it was Adam, talking about the importance of sort of peeling back the curtain to look at the process of research. So I'll show you some of that rather than just sort of perfect results. So thinking about context, it's not just kind of the information ecosystem context, but individual context of how we process information, how we understand, how can we understand how people use and interface with their Facebook messages. So we designed an experimental study at NCI, that's also very much a mixed method study. We wanted to look at how users of social media, in particular Facebook, navigate and evaluate simulated cancer messages. What factors influence their attention? What do they look for? What are they looking at? What factors impact their perceived trust of the source? And also message credibility. So we ask people, do you think this is a believable message? And we want to look at the process they go through to make that determination. So to sort of really simplify, we collected baseline data for 52 participants. We got a very nice balance of race and ethnicity, gender, and health literacy levels to get them to come in, and we showed them simulated Facebook feeds, and we collected eye tracking data as they were looking at these feeds. We also gave them a survey questionnaire where we ask people questions related to source and message credibility, what they endorse, would they share this message with their friends on on Facebook. And we also measure their health literacy using a rapid, health literacy test. I know it's not perfect, but it was one way of getting at something that's not just what they put down as their education level. And then we did a careful cognitive interview. We have them go through the process they, had just been, undergone to talk about the, basically qualitative interviews, and then we debrief them. So if they got something that wasn't credible, we ensure that they left knowing that vaccine doesn't cause all these problems, for example. So the 4 conditions we gave them were whether the message was narrative or non-narrative based, because we were interested in the format of persuasion. We gave them different sources, government, agencies, health organizations. Some of these are real, some of them are not. Individuals, these are just people, people's name. And I know this is one major limitation, is these are not people that they know, the participants are familiar with. So we want to pretend, we tell them to pretend this is somebody in their Facebook network. And then we gave them messages that are evidence-based and not, and the 2 topics, these are the 2 main topics that are most popular for misinformation in the world of cancer. That is HPV vaccination and sun safety. So this is like a gaze plot just to show you kind of, would be sort of a way we designed the study. And then you see these different colors are basically different areas of interest. So we want to look at whether they are looking, I'm just going to try, looking at the source, the text, or the image, or the overall post that they were being asked to look at. So we define these, as you can see, 1, 2, 3, 4 reflect the different areas. So overall, we found that after adjusting for pixel counts, getting a sense of, we don't want to just count more for there's more stuff there, right? Oops, sorry, go back. I was told going back isn't easy. Okay, so people spend a lot of time on source, almost equal amount of time on source and text, and much less on image in general. This is like not, stratified in any way. We also found that overall there was more time spent on narrative-based messages, and also when the source is an individual, it seemed to garner more attention. The others, we didn't find any differences. And those of you who are familiar with experimental design, you're probably already seeing you have too many cells and the cell sizes are too small. You can't find significance. We know all of that. So there are many things we would do differently, but we wanted to give an overall sense of, kind of where people are, what they're looking at. So we connected sort of that eye tracking dwell time data, which we didn't find a lot of significance to then connecting a few things. So how do people decide what source to trust? So source type, like I said, there were 3 kinds, and we asked them, do they trust that source? And we want to see if when they trust the source, do they believe in the message from that source more? And when they trust the source, do they spend more time looking at the source or not? And those of you who are familiar with theories knows there could be different explanations of either findings, right? Like you are more skeptical because you've never seen the source, so you're scrutinizing, or you're like, I like this message because it's from someone I trust, so I look at it more. So because it's so exploratory, we weren't able to, our hypotheses were pretty open-ended. We had some directions we were hoping to look for. So some of the high-level findings, people generally reported higher trust in government agencies than individuals. However, if you look at stratified by veracity, meaning people who are, among people who got non-credible information, they still reported trusting the organizations more when the message is non-credible. And we see some really cool qualitative findings. People talk about really trusting the CDC. And again, the caveat is these are people who are willing to come into a science organization and do this research. So they probably don't have very poor trust in, say, National Institutes of Health. But they said we look to CDC, and they mention a lot of familiar agencies' names, and they also talk about reputable medical organizations such as .gov website, Johns Hopkins or Mayo Clinic. They say they trust that more. And we found a number of interesting quotes on what I call citizenship fake news detection. This idea that people post stuff out there, I know it's not real, and I go on and I tell them that's not real, and then put a link for them to go and read about it. So, and people talk about, I know they probably didn't do it intentionally, but I find ways to, tell them to check their sources. So that was an interesting observation that people say they observed a lot of that happening and they want to do something about it. We also wanted to look at whether participants' health literacy and the various message features affect message believability. And then we very much try to connect that to dwell time. And I can say that we did find a positive association of higher health literacy individuals more correctly rating. So they say that evidence-based messages are more believable than non-evidence-based messages. And we didn't find that difference in among people with limited health literacy. We did find that limited health literacy individuals spend more time on the source of the posts rather than the text or other parts. They are looking, they're scrutinizing. We also found non-evidence-based narratives were the ones that garnered most attention on the text part. So we were very interested in the text AOI because we think that's a place where a lot of that credibility work has to happen because you're looking for argument, and supporting evidence and so on. So those were the only really significant, findings or associations. We tried every which way. The sort of attention, eye tracking data did not produce anything meaningful. We really did all kinds of sort of investigation in terms of believability. So basically, attention did not factor in very much in the sort of credibility assessment. What are the implications? A lot of things we wanted to look for and we wanted to find, we didn't find, but we did find that source was an important area that people look to, at least in our experimental study. We also hear that people say they trust government agencies, but we didn't see a difference in the credibility assessment of health organizations and individuals. So you can imagine these bogus organizations. So we say, I'm from National Cancer Institute. I know it's a real government agency. But if I say National Federation of Cancer Research, I just made something up. But a lot of people think, well, that sounds legit. So the idea that we can have illegitimate organizations masquerading as credible health information sources, I think it's a real concern. So I think about issues of branding. How do we cultivate trust and maybe leveraging influencers or trusted sources to get that source right? So we have to have source trust, and to enable message perceived credibility. Yes, we have a lot of bias in our sampling frame. We have people who have to trust to a certain extent, the government and research and science to be enrolled. In the experimental setting, sometimes I feel very frustrated. It's not how everyday people interface with the barrage of messages. Like today we heard about the volume and just the rapidity of getting messages. So we gave them a lot of time to think through things. So I think that's another bias. We want to do an experimental study, but it was not a true RCT. So there are a lot of exploratory components. So if I were to do it again, I think I would stick with one or the other rather than try to answer all the questions we wanted to answer all in one study. Also, sample size and complex design definitely impeded us from finding a lot of significant things. So in closing, I want to just highlight what in the last 3 years of reading and talking to experts, what we know about misinformation on social media. We know that echo chambers are real and they are enforced every day. Even today, this morning, we hear about people's self-curated content looking for messages, ways to find things they prefer to see that reinforce like-minded conversations and attitudes. We also know falsehoods spread easier and faster. Sometimes it's because of information vacuum. Sometimes it's because it's simplistic. So think about simplified causes and remedies of a disease and things like that, or pre-established beliefs. So as everybody knows, and I'm looking forward to hearing more later on, with a rapid spread, such as the coronavirus, there's real fear there. So it's not just people intentionally going after misinformation, there's an information vacuum, and therefore people are looking for things that perhaps are a little bit easier to digest. In contrast to sort of the simplified definition, I think credible health information tends to be complex, nuanced, and uncertain. That's the nature of science and science communication. Evidence is evolving, sometimes even changing and inconclusive at times. So disinformation campaign often create this sense of false equivalency. So there's an impression that there's a lack of truth when there is truth, such as vaccine and many other topics. So these becomes topics that are very hard to tackle because they have created this idea that there's no consensus, right? So I love the quote from David Broniatowski's AJPH paper, which was published during our working group days, to say that there's a risk that these Russian accounts and the bots and trolls create false equivalency and therefore eroding consensus on vaccination. I think that's a critical point to think about. Lastly, the industry's attitudes, and I'm happy to learn more from our industry partners. Attitudes, policies, and practice towards misinformation and the role of content moderation are constantly evolving. So you may have seen, if you've seen me talk, I've had a similar graph, but every time I do a talk, I update the sort of priorities. And because of the time limitation, I'm not going to be able to read through it, but these are the 4 areas I think we need to invest a lot of our time. And did anybody, I think somebody want to take a picture. Sorry, I just want to let you take a picture. And happy to chat more about it. And then my last slide is really thinking about a divided world that we live in, and as social scientists, what can we do about it? I think we need both basic science, like the experimental study, and applied real-world science. We need to bring people together, and this is a great forum for that, multidisciplinary projects. And the topics that we all tackle have a lot in common. So think about infectious disease, medical hoax, debatable or sensitive health topics such as vaccine, abortion, gun violence, climate change. I think the mechanisms to study these things are also very shared. Mistrust, fear, uncertainty, racism and xenophobia, emotions, identity, values. We've heard these words repeated over and over. And how to do it is really where I'm most interested. I think we need to go beyond traditional methods to think about data mining, experimental design, use of eye tracking, pragmatic trials, and qualitative. I'm originally trained in qualitative research, thinking about discourse analysis, what's behind the libs, what's the intention of sharing, so then we can inform interventions to improve public health. So thank you.